There really does seem to be this nihilistic or fatalistic approach to ER thoracotomies or resuscitative thoracotomies in trauma patients. But this scenario here is probably one of the best possible scenarios associated with the higher likelihood of survivability. And those indicators for performing a thoracotomy also happen to be the predictors of outcomes. And so how do we make the decision to perform a thoracotomy? The guidelines have all been recently updated, both in the pediatric as well as adult populations. But just to summarize, mechanism of injury. Patients with penetrating mechanisms will have better outcomes following a thoracotomy than blunt trauma. And just think about someone who's involved in a high-speed motor vehicle crash. Oftentimes they have significant injuries to the head, the torso, the spine, the pelvis. And so it's not surprising that when these patients lose their vital signs, oftentimes they may have injuries that are not amenable to repair simply by opening their chest and cross-clamping their aorta. Now, when someone comes in following a stab wound or GSW, these patients actually have a much higher likelihood of survival when we do a thoracotomy versus blunt trauma. Additionally, we want to look at the location of injury. Patients with primarily chest or intrathoracic injuries, when you perform a thoracotomy, you might see the cause of the bleeding there and you can deal with it. So that's going to be better than if someone, for example, has major bleeding into the abdomen or bleeding into the street from a significant extremity injury or multi or polycavitary injuries. The other thing we want to look for are signs of life. Is there pupillary reactivity, agonal respirations, or even better, put the ultrasound probe on the heart and rule out a cardiac tamponade and see if there's any evidence of PEA or cardiac activity whatsoever. So patients coming in with a penetrating mechanism, signs of life, and evidence of primarily intrathoracic injuries will have great survival. So what's great survival mean? Well, in a 2020 study of approximately 50 trauma centers with over 1,000 thoracotomies, standard left anterolateral thoracotomy versus a clamshell thoracotomy, survival was 6%. So not zero.